Hi, everyone. Thank you so much for joining. And we're going to jump right into this session with a little game that you may have heard of before called word association. So here's how you play. In a moment, a phrase is going to appear on the screen. And as soon as you see that phrase, I want you to jump into the chat with the first words that come to your mind. So here's a quick example. If dog appears on the screen, I might enter walk, bark, pet. Okay? All right, so here we go. The phrase is access to care. So what words come to your mind when you hear access to care? Just take a moment and enter those into the chat. Personally, when I think of access to care, some of the first words that come to my mind are hospitals, primary care, disparities, but I want to hear what you all think. So take a moment, enter your thoughts. Okay, I'm seeing, let's look at some of these. I'm seeing poverty, affordable, inequality, expensive, yeah. Insurance, networks. All right, well, you all are on the right track. We are going to cover many of these words and phrases and elements in today's session. And so with that, welcome to Improving Access to Healthcare, Medicaid, Telehealth, and the Health Workforce. My name is Kelly Hughes, and I direct our health access, cost, and coverage work in NCSL's health program, and I will be your moderator for today. And I also just want to take a quick moment to thank our partners at the Health Resources and Services Administration for their support of this session, and to you all for joining us today on this Friday afternoon or late morning. And also to all the new legislators and staff in the audience, welcome to NCSL. All right, so let's get into today's program. I think we all can agree that the US healthcare system is really complicated. There are a lot of stakeholders and a lot of money involved in the healthcare system. And there are private payers and public payers, and then there's differences in the regulation of those payers at the federal and state levels. And we also know that having access to quality healthcare is important for promoting health, not only just for maintaining health, but also for preventing and managing disease and reducing disability and premature mortality. And all of those can have really costly outcomes to taxpayers and state budgets and at the federal level. And so we also know that there are significant disparities in access to care by sex, race, age, ethnicity, education, and income levels. So in this session, we're going to touch on a few state policy options to increase access to care. First, NCSL's Emily Blanford will provide an overview of state Medicaid programs. And then NCSL's Sydney Enlin will cover the health workforce and telehealth. And then we'll have time to unpack your most pressing questions and just have a discussion as a group. And then we're really excited to wrap up this session with demos of 2 NCSL resources, one of which is a very special sneak peek of NCSL's newly revamped scope of practice policy website. Okay, so before we jump in, I just want to share a couple quick reminders just to help you get the most out of this session. First, and perhaps most importantly, please ask questions. We have questions for you, and we hope that you have questions for us as well. You can submit your questions through the Q&A box, which you see circled on your screen. And it's to the right of the video player. And if you see a question that you like that someone else asked, you can upvote it by using the up arrow. And so we will prioritize those that have been upvoted, but we'll try to get to as many questions as we can. And if for some reason we don't get to your question, we will follow up with you individually. I also want to point out a few features on the platform. So first, you can expand the video player to make it full screen by clicking on those arrows that I've circled at the bottom here on the lower right-hand corner of your video player. And you can also find speaker bios and resources and your poll questions directly below the video player, which we'll talk about in a moment. And then finally, if you need help at any time, you can use the help button on the lower right-hand corner of the page. And if you're unable to watch any part of this session and all of the sessions in this series are recorded and will be available to you through your registration until March 26th. Lastly, there is no way we could cover everything related to access to care in 75 minutes. So my colleague Jack Pitzer is going to share my contact information and Emily's and Sydney's throughout the session. And so we hope that you just jot down our information and reach out to us at any time if you need help, because we are here to serve you. Okay, so now we're going to take you back to your primary school days with a little pop quiz to test your knowledge on access to care concepts. But instead of asking you all these questions at once, we're going to sprinkle them throughout today's session. And so here's how it's going to work. Along the bottom of your screen, you should see 4 poll questions. Don't do anything yet. Those are going to be your quiz questions, and we will prompt you when to take which question. And then as soon as you answer that question, your answer and everybody else's will aggregate and they will appear on your screen so you can see how your peers have also answered. Okay, so we're going to get started with poll question number 1. You can click that on your screen now and answer that. The question is, which of the following are main elements of healthcare access? The answers are, or the potential answers or responses are A, coverage, B, services, C, workforce, D, timeliness, or E, all of the above. So I'll give you another minute or moment to answer. And then we will wrap up and review. So I'm going to ask my colleague, Jack Pitzer, to share what he's seeing.
Yeah. Thanks, Kelly. It looks like some people are thinking coverage, but a majority are led to believe that all of these are elements of access to care, about 88%.
Great, thank you so much. Okay, let's talk about the correct answer, which is E, all of the above. You all, the majority of you are right, so congratulations. And coverage is not a wrong answer, so congrats. So according to Healthy People 2020, there are 4 main elements of healthcare access: coverage, services, workforce, and timeliness. And so the topics that we're going to be covering in this session span all 4 of those elements, with Medicaid as a primary source of coverage for many Americans, the health workforce, telehealth as a mechanism for delivering services, and then timeliness really cutting across all 4 of those elements, but especially with telehealth. So now I'm going to kick it off or hand it over to Emily Blanford, who is our resident Medicaid expert at NCSL, and she's going to give you the 101 on all things Medicaid. She has a wealth of knowledge in this policy area, as she previously worked in a state Medicaid program for over 12 years. And you can also read more about her experience in her bio below. So Emily, the floor is yours.
Thanks, Kelly. Glad to be here with you all today talking Medicaid. Now it's time for our second poll question. True or false? It's optional for states to participate in the Medicaid program. We'll pause just a bit here to give everyone a chance to plug in their answers. All right, so thanks all for taking a stab at that poll question. We'll get to the correct answer here in just a bit. So Medicaid is always a hot topic for state legislatures, and I like to start off with some quick facts to explain why. So nearly 30% of total state spending on average is for Medicaid. So that includes all funding sources, both state and federal. So nearly 1/3 of state budgets are going towards Medicaid programs. And nationally, we spend about $600 billion annually on our Medicaid program. And in addition, nearly 45% of births in this country are financed by Medicaid and provides coverage to nearly 40% of children, making Medicaid a significant source of healthcare coverage and access for people in this country, particularly pregnant women and children. So those are some of the reasons why we're always talking about Medicaid, but what is it? To explain, I like to start with the difference between Medicaid and Medicare. A lot of us mix up these 2 programs, which is so easy to do. So both programs were enacted in 1965. Medicare is coverage for older adults with eligibility primarily based on age. Medicaid eligibility is largely based on income and covers populations as defined in law, including children and parents, pregnant women, and people with disabilities. And for states that have chosen to expand Medicaid under the Affordable Care Act, also includes adults without dependent children. Now, Medicare is administered and financed solely by the federal government, so state legislatures don't have much of a role there, whereas Medicaid is a federal-state partnership. So both the states and the federal government contribute funding to the program. States are responsible for administration of the program, and the federal government provides oversight. Now, the agency responsible for providing that oversight is the Centers for Medicare and Medicaid Services, or CMS, which is housed in the U.S. Department of Health and Human Services. Now, I also just want to briefly mention that NCSL has some federal experts housed in our DC office. We have Haley Nicholson, who is our Senior Policy Director for Health and Human Services. She's here with us today, and you can always reach out to her for updates on what's happening with these programs at the federal level. So back to our pop quiz question. Medicaid is an optional program and it is not mandatory for states to participate. But all states do choose to participate, and Medicaid is the largest source of federal funding for states. So now I'd like to briefly talk about what that funding partnership looks like or how it works. So the Federal Medical Assistance Percentage, or FMAP, is used to determine how much the federal government contributes to a state's Medicaid program. So FMAP rates, they vary by state, and they're largely based on per capita income in the state. The minimum amount of FMAP is 50%, meaning for every $1 a state puts towards their Medicaid program, the federal government will match it with an equal dollar. So states with the higher per capita incomes will get closer to that 50% match, while states with a lower per capita income will receive a higher FMAP percentage. So for example, as you can see on this slide, the highest FMAP rate is about 78%. Meaning the federal government provides about 3/4 of the funding for that state's Medicaid program. Now, I also mentioned FMAP because I imagine it'll be a particular hot topic of conversation during legislative sessions this year, because FMAP is also used as a tool to provide states with fiscal relief. So for example, the COVID pandemic has led to significant increases in Medicaid enrollment and caseload, with dwindling state revenues, leaving it harder for states to cover that increased enrollment. So currently, states are receiving an enhanced FMAP rate of an additional 6.2% to help cover these enrollment increases, as well as provide general state fiscal relief. Now, this enhanced FMAP rate is currently in place for the duration of the public health emergency period. And there's been a lot of uncertainty regarding when that public health emergency might come to an end. Currently, it's been renewed through the end of April, but the Biden administration recently communicated to governors that they anticipate extending the public health emergency for the duration of 2021. However, that hasn't been done just yet. And the Biden administration also indicated that they would give states at least 60 days notice prior to the ending of the emergency period to try and help states prepare. So again, with this uncertainty of when that enhanced federal funding might end, imagine this is a topic of conversation in legislatures to plan for that end in funding. Now let's talk a little bit about administration of Medicaid. Each state has something called a Medicaid state plan, which is the agreement between the state and the federal government describing how the state administers the program. So the state plan, it defines groups of individuals to be covered by Medicaid, in essence, who's eligible, what services are covered. It includes provider reimbursement methodologies and other administration and oversight activities. Now, CMS reviews and approves these state plans and any state plan amendments and provides oversight to ensure states are actually adhering to what's in their plans. Now, states also have the option to seek some flexibilities from these requirements in their state plans through the use of waivers. Now, waivers literally waive certain requirements in the state plan to try and design programs that might meet their unique state needs. For example, Section 1115 waivers have been widely used across states to test all kinds of new ideas, or target services to particular areas in their states, or target services to particular groups of individuals. So for example, as you can see, many states have used Section 1115 waivers to design substance use disorder treatment programs to respond to the opioid epidemic and substance use generally. Now, another key waiver authority used by states are called home and community-based services waivers, or HCBS waivers. Now, home and community-based services waivers are an option that allows states to serve individuals with disabilities and older adults in community settings, for example, a client's home, rather than in more costly institutional settings like nursing facilities. Now, one key thing to note about all of these waiver authorities is that they must be budget neutral to the federal government, meaning the waiver essentially cannot lead to increased federal spending. So now let's talk a little bit more about the legislative role when it comes to Medicaid programs. There are a few methods, or what I'll call policy levers, that can be adjusted to impact costs and access, coverage, efficiencies, and health outcomes. Now, some of these policy levers, they can be adjusted administratively by your state Medicaid agency, meaning they don't necessarily need additional legislative authority to implement. while other areas can benefit from legislation, or depending on the state, legislation may be required to make changes that can lead to improving outcomes and better controlling costs in Medicaid programs. So let's start with that first policy lever, eligibility. Now, Medicaid eligibility, as we discussed, is based on income and is set as a percentage of the federal poverty level, or FPL. Now, there are mandatory eligibility levels that states have to cover in order to participate in the program. And then states have the option of covering higher income levels. So for example, many states have chosen to cover pregnant women and children at higher income levels than the minimums. Now, because Medicaid is an entitlement program, anyone who meets these eligibility thresholds is covered by the program. And so through traditional options or your Medicaid state plan, there aren't necessarily a lot of opportunities for legislators to adjust eligibility levels. However, as we talked about, waivers can allow states some flexibility in this area, either to potentially target services to specific populations or to potentially place limits on enrollment if you're looking to control spending. Now, the next policy lever we're going to discuss are benefits. There's both mandatory and optional benefits within the Medicaid program. As with eligibility minimums, there's a list of mandatory benefits that all states must cover if they choose to participate. And then there are optional benefits, which a state can choose to cover or not. And this is an area where the legislature might have more of an impact on the program by either choosing to cover these optional benefits or not, or in the time of economic downturns, maybe deciding which optional benefits to eliminate or potentially reduce in some way. So there's a little more flexibility regarding optional benefits for state legislatures to consider when trying to impact costs and outcomes in the Medicaid program. Third policy lever we're going to talk about are delivery systems. So states take different approaches to the actual delivery of services, and you'll hear this referred to often as delivery systems. Now within Medicaid, most states use managed care and managed care organizations, or MCOs, as the primary delivery system for the program. So MCOs are essentially used to coordinate services for Medicaid populations. Now, depending on your state, the legislature may be very involved in those delivery system decisions and what they look like, while other states largely delegate the design of delivery systems to the executive branch Medicaid agency. Then the last policy lever I'm going to talk about is provider reimbursement, which is one of the primary policy levers used by state legislatures to increase access and also control spending. So state legislatures can have input or define how reimbursement rates are determined and can increase or decrease rates where needed. A rate increase may be needed to improve access to particular services, for example. Or in times of budget crunches, state legislatures will often reduce Medicaid reimbursement rates. These reimbursement rate reductions, they can be across the board for all provider types or can be targeted to specific kinds of services. So that is a very high-level overview of the structure of the Medicaid program and some of the policy levers available to state legislatures to manage their Medicaid programs. If you'd like more information on these topics, there are a couple NCSL resources that are a good place to get started. You can find those resources by our speaker bios. So if you'd like more information about general Medicaid administration, NCSL's Medicaid Primer for state legislatures is a great place to start. There's also a resource called 10 State Strategies for Improving Medicaid, which provides more details regarding the policy levers available to state legislators and some of the good examples of how states are actually applying those levers. So thank you all so much. I'm happy to take burning questions from the audience at this time.
Thank you so much, Emily. Yes, please, everyone, submit your questions. We want this to be as interactive as possible. We know Friday afternoons can be tough. We want to answer all the questions that you might have. And so we do have one question that came through, Emily, and it was around why a particular, state has or district has a high percentage, a high FMAP percentage. So can you just kind of summarize that again? Like, why does it vary across states, the FMAP rate?
Sure, of course. So the FMAP rate is largely based on average per capita income in a state. And so it's kind of got an inverse relationship to the FMAP rate. So the higher per average income, the lower your FMAP rate is going to be. So I can't speak to DC in particular. I'm not sure what their per capita average income looks like, but my guess is they've got a lower per capita income, which is what drives a higher FMAP rate for DC in particular.
Great, thank you so much. I'm just glancing to see if there's any other questions, but right now I don't see any. So what we'll do is feel free to submit more questions related to Medicaid throughout the rest of the session, and we'll get those at the end. And so for now, thank you all so much thank you, Emily, and thank you for your question. And we're going to just get into some other elements of access to care, including health workforce and services via telehealth with Sydney Enland. So Sydney covers access to care, health workforce, and rural health policies in NCSL's health program. And she has experience working in a state legislature and for a committee in the US House of Representatives. Make sure to check out her bio below. And with that, I will turn it over to Sydney.
Thanks so much, Kelly, and thanks to you all for being here today. I'm so excited to be presenting on health workforce and telehealth. So as Kelly mentioned, many individuals experience differences in accessing healthcare services, especially those living in rural and underserved areas. Physician shortages can create barriers to accessing timely and appropriate care, which can ultimately lead to negative health outcomes and create significant costs for states. And in many areas, the supply of healthcare providers just cannot keep up with the demand for healthcare services. And physicians who practice in rural areas often serve large geographic areas that require long travel times, either for the doctor or the patient. The American Association of Medical Colleges projects a physician shortfall between 54,000 and 139,000 by 2033. So there's a few reasons for this. The population of those aged 65 and over is projected to grow by 45%. And there just is not enough practitioners to fill the gap left by those retiring physicians. More than 40% of currently active physicians will be 65 or older within the next decade. There's also growing concern about physician burnout, especially during the COVID-19 pandemic. And that suggests physicians will be more likely to accelerate than delay retirement. New medical students are more likely to stay in the area where they did their residency, and more of those residencies are concentrated in urban areas. And a large majority of those students are entering specialty care because historically, reimbursement rates for specialty care are much higher compared to primary care, which means fewer primary care providers. I do want to mention that these statistics really only speak to physicians, but there are many other types of health professions shortages, like dentists and mental health providers. There is good news though. States do have the opportunity to utilize a variety of policy levers to alleviate these workforce shortages. So the first policy lever that states can examine to address workforce shortages is provider recruitment and retention programs. State recruitment and retention policies aim to bring healthcare providers, or even keep them, in underserved areas to maintain and increase access to care. Scholarship and loan repayment programs provide students in health professions with scholarships or loan repayment or forgiveness. In exchange, the students commit to practice in certain areas for a specified period of time, often at least 2 years. But in recent legislative sessions, states have looked at extending this practice time requirement in order to help keep those providers there. The National Health Service Corps is a federal program that provides loans and scholarships to medical and dental students with the goal of bringing primary care providers to underserved areas. This program is administered by the Health Resources and Services Administration. In addition, through the state loan repayment program, at least 41 states and the District of Columbia receive federal cost-sharing grants from the National Health Service Corps to assist in their operation of their state loan repayment programs for primary care providers. Pathway programs engage students from kindergarten through college age and introduce them to healthcare careers. These pathway, or even they're often called pipeline programs, focus on recruiting students from backgrounds that are historically underrepresented in healthcare professions, with the goal to promote greater diversity in the healthcare workforce. Students in pathway programs may be more likely to return to practice in their communities, such as rural or other underserved areas. Next, I want to touch on leveraging some non-traditional practitioners to help increase the reach and capacity of existing providers. Utilizing these practitioners who have the appropriate training and experience and integrating them into the healthcare system can help alleviate pressures on primary care capacity and help fill the physician shortage gap. So community health workers are the first provider I want to talk about. They are members of healthcare teams that work closely with patients and providers to control chronic illness through education and counseling, communication with providers, and a variety of other services. They traditionally work in the same communities where they live, and they have an understanding of the community in which they serve. Community health workers also help connect patients with additional support services outside of a physician's practice. Peer support specialists use their lived experience of recovery from mental illness and/or addiction, plus skills learned in formal training, to deliver services in behavioral health settings. The services these practitioners provide often include building relationships for those in recovery, leading recovery groups, and providing mentoring and goal-setting opportunities. Dental therapists are a relatively newer provider. They're members of a dental team who provide preventative and restorative dental care. The precise role really does vary and depends on their education and various state dental regulations and guidelines. They practice under varying levels of supervision by dentists, allowing these providers to really meet the needs in non-traditional, tribal, school-based, and community settings. Dental therapists actually originated in Alaska as a way to serve rural tribal communities. Community paramedics are paramedics trained to provide non-emergency services to patients and perform an expanded role within their scope of practice. They visit patients in their homes or other community-based settings. They aim to connect these high-risk and underserved patients, such as those frequent users of the emergency department, with primary care services. And this past summer, we released a policy report featuring a few of these providers. It is available on NCSL's website and listed in the resource section below. All right. So now before we dive into our next policy lever, it's time for another poll question. This one is true or false? Scope of practice only relates to doctors, nurse practitioners, and physician assistants who can enhance access to primary care. So you'll click on poll question 3 on your page and just take a moment to answer the question. Give you just a couple more seconds. All right, thanks so much, everyone. We will circle back to the answer at the end of this section. So another policy lever to alleviate workforce shortages is, you probably guessed it, examining scope of practice laws. So scope of practice describes the procedures, actions, and processes that a healthcare practitioner is permitted to undertake in keeping with the terms of his or her professional license. Since each state has its own specific laws and regulations regarding the responsibilities of these providers, the range of services performed really varies from state to state. You, as legislators, are asked to balance between extending the use of health professionals to fill in shortage gaps and ensuring that they are able to perform their duties safely, appropriately, and have proper training and experience. State legislatures consider many aspects of a healthcare professional's practice. These include prescribing privileges, physician oversight requirements, and also some specific practice site requirements. Legislatures have made extensive changes to scope of practice requirements during the pandemic, mostly related to supervision requirements. And most of these, they're really only in effect for the duration of the public health emergency. We will be tracking the legislation upcoming this session to see if any of these changes will be made permanent. And NCSL maintains a website on scope of practice that we track legislation on various policy areas for 5 different provider types. For example, we track that supervision requirements and prescriptive authority for both physician assistants and nurse practitioners. In total, the site has extensive state-specific legislation for 17 policy areas, with more to come in the future. And we'll walk through this website at the end of the session, so be sure to stay tuned. So now let's circle back to the previous trivia question. So true or false? Scope of practice only relates to doctors, nurse practitioners, and PAs who can enhance access to primary care. And that answer is false. All healthcare practitioners have a scope of practice. And again, it can really vary by state. And last, but certainly not least, our final poll question on telehealth. So telehealth can only be used in rural areas, allows providers to communicate with patients, has been utilized more than ever during the COVID-19 pandemic, is only available for primary care, or all of the above. Please select all that apply. Take a few moments, click on the poll question number 4 below the screen. And I'm going to have my colleague Jack summarize what he's seen as you answer the question.
Yeah, results are rolling in. Not too many people think that it can only be used in rural areas. So, and then a lot of people are saying it's been utilized a lot during COVID and that it allows providers to communicate with patients.
Great. Awesome. Thank you so much, Jack. Thanks so much again, everyone. We'll circle back to this answer again at the end of this section. So you probably guessed, we're going to bring it home with telehealth. Telehealth uses technology to provide healthcare and other health-related services remotely. This includes communication and education between patients and providers, as well as between providers themselves. Though it doesn't increase the size of the provider workforce, it can help increase efficiency and extend the reach of existing providers. Telehealth is not a service itself. Rather, it's a mechanism for delivering healthcare services, which is a key component of access to care. Telehealth has really been a hot topic for state legislatures for years, but has really exploded during the COVID-19 pandemic as a mechanism to safely provide healthcare to patients while reducing the risk of exposure. So telehealth can allow patients living in rural areas to receive care in their own communities and even their homes, as healthcare providers may screen, triage, and treat symptoms remotely. Telehealth can reduce exposure to COVID-19 and other illnesses, which may occur while visiting healthcare facilities. It can also reduce patients' costs and burdens associated with lost work time, transportation, and childcare needs when needing to travel to an in-person appointment. And telehealth can also shorten wait times to see a provider, especially those needing specialty care. So there are 3 primary modalities for utilizing telehealth. Real-time communication allows patients to connect synchronously with providers via video conference, Skype, Zoom, Microsoft Teams, all of those kinds of platforms. Store and forward refers to the transmission of data, images like x-rays, sound, or video from one care site to another for evaluation. And remote patient monitoring involves collecting a patient's vital signs or maybe some other health data while the patient is at home or another site, and it transfers that data to a remote provider for monitoring, and they can provide a response as needed. By improving access to lower cost primary and specialty care, telehealth can also provide timely, accessible care in lower cost environments and help reduce expensive emergency room visits. Aside from most primary care settings, telehealth is also used in a variety of specialty areas, such as behavioral and oral health. Legislatures can modify many aspects of telehealth, including reimbursement, entering into compacts, and the types of providers and locations allowed to provide telehealth services, for example. We are also seeing an increase in telehealth utilization in response to COVID-19 and states are modifying their requirements to increase access during the pandemic, especially allowing for reimbursement for telephone calls, which was previously rarely allowed. NCSL has a number of resources on telehealth. We track telehealth legislation in our Health Innovations database, which Emily will walk you through at the end of this presentation. We also track telehealth COVID-19 legislation in our COVID-19 state legislative database. And we are also working on a policy toolkit, which will contain about 7 mini briefs on various aspects of telehealth. These will be published on a rolling basis between April and August of this year. So let's see how you did on the last trivia question. So telehealth can only be used in rural areas, allows providers to communicate with patients, has been utilized more than ever during the COVID-19 pandemic, is only available for primary care, or all of the above. And the answer is B and C. Telehealth can be used in all places, urban, underserved, rural, and is also available in a variety of settings and care. And with that, I will turn it back to Kelly.
Yes, thank you so much, Sydney. That was excellent. Okay, so now we're going to open it up for questions from the audience, and we've already got a few in our chat, so I'm going to share those with Emily and Sydney now. So starting with Emily, we have a question about Medicaid and social determinants of health. So can you talk a little bit about Medicaid programs and how they're addressing social determinants of health, and also what state legislators are talking about in this regard? And just before I turn it over to Emily, just as a refresher for those that are maybe newer to this concept, social determinants of health are conditions in the places that people live, learn, work, and play that affect a wide range of health and quality of life risks and outcomes. That is the CDC definition. And you may have heard things like, you know, your zip code impacts your health, and where you live can influence how long you live. So that kind of nods to social determinants of health. And so with that, I'll turn it over to Emily.
Thanks, Kelly. And yes, so social determinants of health have definitely become a major topic of conversation, both amongst Medicaid agencies and the executive branch, as well as state legislatures. And there's a couple examples I can think of off the top of my head, but the biggest one is really housing, and in a conversation about how housing can help complement Medicaid and maybe reduce Medicaid spending in some areas. So, you know, earlier I mentioned the existence of home and community-based services waivers, where you're trying to serve people in a community-based setting rather than an institution. But a lot of times you run into issues with how to get actual affordable housing. And so sometimes when that housing isn't available, people are ending up in those more costly institutional settings. And so there's a lot of work around. So how do we ensure that accessible and affordable housing is available and assisting individuals transitioning to those kind of community settings? Because traditionally, a lot of times Medicaid would strictly only cover health-related services, but there's been more of a recognition that we can cover maybe some of those housing services, help someone, you know, pay their security deposit so they can secure a space to stay. So we're seeing stuff in that kind of realm, helping, you know, reduce costs in terms of institutional. But then there's also you know, asthma is a big thing, and uncontrolled asthma leads to a lot of emergency department visits, which again drives a lot of Medicaid spending. And traditionally in the past, you know, Medicaid didn't allow things like vacuuming a place to get rid of allergens in a house or providing special bedding. But more and more we're seeing the federal government is allowing for that, and we're seeing more conversation about covering that as a Medicaid program decision.
Great, thank you so much, Emily. We have another question for you too on Medicaid and block grants and how block grants work with Medicaid, or do they? Can you elaborate on that a little more?
Sure. So for everyone who may not be familiar with block grant, let's just start with what that, well, let's start with how Medicaid is financed. So right now, we call it an entitlement program. The federal source of financing is essentially guaranteed, and it's provided on an as-needed basis. So if a state's enrollment goes up and state spending goes up, the federal funding also will go up in accordance with that increase. So a block grant, the idea behind it is it's more a set amount of funding. So it's not meant to increase with need. It's just meant to be the chunk of funding you get to cover your Medicaid program. Now, sometimes It can be one big block grant to cover the whole year, or it can be one block of money per person. So you can spend this much per individual enrolled, or you can spend this much on your whole program. And so before now, no state has done block grant financing in their Medicaid program. It has not been approved until very recently, when the Trump administration approved a block grant proposal from Tennessee. And so it'll be really interesting to see if the Biden administration continues forward with that. Tennessee is doing a kind of modified block grant proposal so typically in a block grant, once you hit the ceiling on your block grant, you're out of money. But in Tennessee's example, they built in some allowances for if caseload and enrollment goes up more than they expected, they can still get additional federal money to support that. So yeah, it'll be really interesting to see how that works out. But yeah, to date, no one has used block grant financing in Medicaid.
Great. Thank you so much, Emily. Sydney, question for you on telehealth. So what are the barriers to telehealth entry for providers, and what are the potential drawbacks to telehealth? So kind of what are some of the potential drawbacks of telehealth, and what challenges might providers experience in using telehealth?
Yeah, so I would say, one of the things that we hear, maybe anecdotally, is concerns around privacy, telehealth, HIPAA, are your platforms secure? Who's going in and out of rooms? Who's looking at the computers? We're storing medical data on the computers and using the internet and transferring images. We hear a lot about that. We also hear, debates about cost effectiveness. Is it really cost saving? Is it come out even? And I think there's still a lot of information out there to be collected on, does it really decrease significantly for states, or is it sometimes increase because you have more keeping up with technology, costs around that, so maybe your care prices go down, but your expenses on the business side might go up with how much it takes to maintain, all of your infrastructure. I think for challenges providers experience, we see a lot of reimbursement. Some states only reimburse for one modality, two modalities. Sometimes it's at a lower rate. Some states don't have private payer laws surrounding, private insurance coverage of telehealth. So reimbursement can kind of make it challenging to providers to want to participate. Some states also limit the type of providers or even the specialties that can be provided through telehealth. We have seen during COVID a real uptick of mental health and behavioral health services being utilized through telehealth, as people just need a little more help, coping with the pandemic and all of the life changes that are going on. So those are a few that I would say.
Thanks so much, Sydney. And then we also got a question about leading strategies to save critical care hospitals in rural areas from financial collapse. And this is a really, unfortunately, a really important issue. And it certainly hasn't, we haven't seen any of those hospital closures kind of lighten up or slow down in the wake of COVID. And so this is something that we track really closely at NCSL. I wish there was a really, straightforward response. We're seeing a lot of a variety of policy actions that state legislatures are taking. I think my colleague, Jack Pitzer, shared a couple resources in the chat. So those are really great and go into a lot more detail, which we'd encourage you to check out. But some of them are really looking at providing some targeted financial assistance and technical assistance through either general fund appropriations or through other means. They're also establishing task forces and special committees that are really looking at kind of the unique situation and context of each rural hospital or system. Some are, looking at payment reform, so kind of transitioning away from fee for service and looking at more alternative payment models that really that provide payments for each individual service and procedure. Looking at enhancing Medicaid is another option. And maybe Emily, you can share more about that too. And then also leveraging other rural health facilities. So looking at community health centers, school-based health clinics, Some of those receive federal assistance and are located in areas that serve underserved populations. And so those can also be leveraged. Those are just a couple examples. There's a lot more that we can share on this. So definitely encourage you to look at those resources and also reach out to us because we can share more targeted information and policy levers as a follow-up. Do you want to say any more, Emily, about Medicaid and how? No? Okay. Any other questions? I don't see any in the chat. And while you all are thinking of all your great questions, I have a couple for our panelists too. So Emily, we know that the COVID pandemic has impacted just about every aspect of the healthcare system and public health system, and Medicaid certainly hasn't been spared. So what are some of the ways that COVID has impacted state Medicaid programs?
Sure, yeah. So as we talked about a little bit earlier, the biggest impact we've really seen is increased enrollment on Medicaid programs. Some states have seen as much as a 20% increase in their caseload, which is pretty significant. And so at the same time, we're seeing all these people enroll. States were worried that they weren't going to have the funding to cover it. But the fiscal picture looks a little better than it did at the start. And so, while there is all this increased enrollment, so far states mostly seem to be able to handle that increased enrollment. So that's been a mostly good thing. It wasn't as dire as we thought it was, I guess, at the start of the pandemic. Other significant impacts to the Medicaid program, specific providers have been very impacted, while hospitals and other providers saw very much increased demand and needs there. We're also seeing providers who weren't seeing any clients because of the COVID, either restrictions or people are foregoing their more preventive regular care. And so there's also an issue of how do we sustain those providers who aren't seeing people right now while also supporting those providers who are seeing all this increased demand. And just one other thing I'd like to mention about COVID, since we were talking about waivers, there's another waiver authority called Section 1135, which is essentially disaster relief waivers, which are something states can use to respond quickly in times of an emergency, such as this public health emergency. And so we saw all the states and most of the territories use those waivers to try and get some flexibilities in their Medicaid programs. For example, we talked a lot about telehealth, and those waivers allowed states to really increase their capacity to deliver telehealth in critical needed areas. Also, as well, get more providers on board and streamline enrollment so that people could really get access to needed services in the time of this pandemic.
Perfect. Emily, we got a question on Medicaid. I'm going to just pitch a question to Sydney just to give you a minute, and then we'll come right back to you, if that's great. Okay with you. So Sydney, while we're on the topic of the pandemic, can you just talk a little bit about how states have leveraged telehealth throughout the pandemic and what kind of trends you're seeing across states?
Oh, sorry. I guess I was going to say we were going back to Emily and you were letting me think on that.
Reverse.
Yeah. So like I said earlier, a lot of states have really expanded their use of telehealth during COVID, right? Like you can't go to the doctor, no one's traveling, no one wants to be exposed to anybody. So we've really seen just a whole uptake in just the usage of telehealth, right? I think one of the biggest things that's changed, and I believe I mentioned this earlier, was allowing for reimbursement of phone calls, right? So before it used to be, you had to have a face-to-face encounter with a provider in order for it to be reimbursed. And sometimes that's, not always possible. And I think beforehand, in my previous questions about some of the challenges that we see is also related to broadband. A lot of areas don't have access to broadband. So if you don't have broadband or internet, it's almost impossible to participate in telehealth. So we've really seen, in order to really increase the access to care, is let's reimburse for phone calls. Let's just get people the care they need. So we'll also be kind of seeing what happens with that. A lot of states have expanded the types of providers that can provide telehealth, especially mental and behavioral health providers. A lot of states really used it, doctors, nurse practitioners, physician assistants, kind of those special or those primary care services. And now we've really seen an inundation of mental health care providers really being able to reimburse and get reimbursed for providing that telehealth services. And I would say probably the last one is, you know, where can you receive telehealth? Sometimes they had restrictions on you had to be in this certain location. They've expanded it to really be like, you can do it in your house and doesn't have to be in these community-based settings. So we've seen a lot of changes, and my colleague, Jack Pitzer, really tracks our COVID-19 telehealth changes. And I know he dropped the COVID-19 database in the chat, and he does a really excellent job tracking everything, all of the changes that have happened to telehealth during COVID-19. So I also want to give a little bit of a plug to go check out that database if you really want to see where states are going. And we'll really be looking in this legislative session to see what changes states will make permanent from these temporary telehealth policies, or if they will go back to their policies pre-pandemic.
Thank you so much, Sydney. Okay, back to Emily. So Emily, can you tell us what is the primary method of Medicaid programs across the primary delivery method, excuse me, across the US? So you mentioned managed care, but are there other common examples of delivery methods that states are using?
Sure. So managed care is the primary delivery model, and there's actually different kinds of managed care. So the main kind of managed care is, as I mentioned, using managed care organizations or MCOs and paying them a capitation or a capitated rate. And so what that means is the MCO gets paid a set amount. We call it per member per month. You might hear people talk about PMPMs, might drive you crazy with the acronyms, but so that's what we mean by capitation. And so in that case, the managed care organizations are responsible for meeting the needs of clients under that monthly amount they get per client. So that means if someone doesn't even show up for services, the MCO still gets paid. Or if somebody shows up and uses a lot more services, the MCO gets paid, but they have to cover those excess costs. And so that is the primary delivery system across the country. Most states use MCOs for the vast majority of their Medicaid programs. But there's another kind of managed care. It's called primary care case management, or PCCM. And it's similar to an MCO, and that MCOs are responsible for coordinating care. And so in a primary care case management model, it's a primary care provider who's responsible for coordinating services there. But it's not necessarily capitation. The other sort of reimbursement model is referred to as fee for service, which is kind of pay as you go. You pay per doctor visit, you pay per hospital visit. And PCCM models are a way to manage kind of a fee for service sort of model. And so those are really the primary delivery systems. And then there's little things you can do within there. You might have heard of something called patient-centered medical homes, which again are very similar to a PCCM model, but specific to people with chronic conditions. But it's meant to have one provider who coordinates the person's entire health profile, as well as addressing their social determinants of health. So we see all kinds of different delivery systems, but managed care MCOs are really mostly what we see across the nation.
Great, great. Thank you for that. And then while I've got you, Emily, so can you tell us about some best practices that states are implementing to ensure program integrity and reduce fraud, waste, and abuse within Medicaid programs?
Oh, that's a good question. I am not as brushed up on my fraud and abuse best practices right now, but I can tell you, one of the primary things is just assuring that you have one entity responsible for that oversight. That's one of the best practices. A lot of states actually have multiple entities who are looking at different aspects of the Medicaid program, whether it be eligibility issues or payment issues, and they live in different areas. And one of the things that's really been found is having one unit, whether it lives in the Medicaid agency or it's somewhere else, but having that one unit sort of dedicated to reviewing and providing that sort of surveillance and full program oversight. I'd say that that's kind of one of the biggest lessons learned, but I'd be happy to provide some additional info on that since I'm a little rusty on that one.
We appreciate your honesty, Emily. Okay, Sydney, you kind of touched on this earlier, but just curious if you have anything else to add. So not every state has great broadband access, particularly in rural areas. So can you just say anything more about how states are working to ensure that telehealth access is available to those that are living in rural areas? And what states are doing?
Yeah, it's a really great question, and definitely, an ongoing issue that we're seeing legislatures, state governments look at. My colleague, Heather Morton, who works in our fiscal program, is actually our broadband guru. And she really covers what states are doing, how they're doing it. A lot of it ultimately comes down to funding. Do you want to put broadband in these rural areas? And, states are really under those budget crunches. And so I think it's always this trying to figure out where can we find little pots of money and how do we get broadband out there? Because it is a really big investment, and who shares the burden of paying for broadband, right? Is it just the state? Do the providers have to pay into it? Is it the cities or towns? So, we see a lot of that. It's a continued conversation. I think it will be ongoing for a really long time. I also think the pandemic has also really brought out this issue even more into the forefront. I really think rural areas have been saying for a long time, like, we don't have access to internet. Like, it's impossible. We in Colorado here in the mountains and the foothills, some people you can't get broadband into the mountains, right? How do you get into those really hard areas of, mountains or foothills? And so I think it's now really going to be up to the states to figure out, well, okay, how do we get broadband and internet, right? And it goes beyond telehealth, right? Students are learning remotely. Yeah. These need access for their students' education. And so I really think this legislative session will see a lot more states looking at broadband a lot more closely to see what they can do.
Thank you so much. You all asked some amazing questions, hard-hitting questions. We really appreciate your engagement. I feel like we've got some access to care experts in the audience. And so thank you so much for submitting your questions. Keep them coming, reach out to us. We are gonna quickly transition to our demo of a couple NCSL resources that are on these topics and we think will be really of great interest to you all. And so with that, I will turn it over to Sydney, I think, who's gonna share her screen to show us the new and improved scope of practice policy website.
Yeah, thanks, Kelly. So this is our brand new scope of practice policy website. It just became public on Wednesday. So we spent a really good amount of time revamping this, kind of bringing it into the 21st century, updating it, colors, and just how the whole thing is aligned. So we're really excited. This site is officially 4 years old now. We've been working on this project. I think from conception, we've probably started this project maybe 5.5, almost 6 years ago. So we've come a really long way on this. So we track scope of practice policies for a variety of practitioners. This is just the homepage. You can learn more here by clicking this about just general scope of practice and our kind of broad, each provider scope of practice. There's state profile pages. So I'm going to just click on one. I'm going to click on Minnesota, and it will take you to the Minnesota overview page where you can look at behavioral health providers. So each topic area, policy area that we feature, education required for addiction counselor credentialing, peer support specialist certification, nurse practitioner, practice authority, prescriptive authority. So we kind of give you a little bit of a teaser in here. And then you can click on the statute to actually go read what the statute says and kind of dive into more information. And then below, it will pull legislation from the database down here to show you what Minnesota has introduced. We track introduced all the way through enacted legislation. So I think already this legislative session in the past 4 weeks, I think we have 82 bills, 87. I'll go to the database page and show you all. And then down here, you can go toggle to another state. So looking at our practitioners here, you can get to any practitioner page by clicking up at the top, or down here, there's all the other practitioner links as well. So I'm going to go to our nurse practitioner page. So at the top, there's just a quick intro on nurse practitioners, what policy areas we track. So practice authority, prescriptive authority and nurse practitioners identified as primary care providers in statute. And then there's this really great map that shows the differences in states. So this is prescriptive authority for nurse practitioners. So you can see there's a wide variation, and then there's a legend below. So we're tracking states that have full independent prescriptive authority, whether there's a transition to independent prescribing period required. So like you have to have 6 months of being supervised by a physician before you're allowed to independently prescribe certain medications, or if there is a continuous physician relationship required for prescribing privileges. And then we have just a little more about prescriptive authority below, below the legend. And then you can, if you wanted to look at practice authority, you can just click over there and the map changes. It's the same layout. We're really excited. And then if you wanted just to learn more about nurse practitioners and just what scope of practice is, they're here. You know, everything here for, you know, who they are, what they do, just a little more info. So let's quickly go to the legislative database. So if you've been on an NCSL database before, this should look very similar. It's set up, you can search by topic, state, what the disposition you're looking for, a keyword, if you even know the bill number, the session year of the author. So I'm actually just gonna see how many, 2021, how many bills we have so far. 87 bills, which is a lot for the first few weeks of session. So, you know, historically, scope of practice bills have been one of the largest topic number of bills been introduced in state legislature. So you can see kind of what it's tagged under, the intro date, who's the author, you know, just a variety of information that you would use. And then you can click this public text link and it will actually bring up another page where you can read the legislation. So we do have that available for you as well. And then we also have some resources here. We have resources on scope of practice. We can refer you to the professional organizations. So the American Association of Nurse Practitioners, the American Academy of PAs, if you want more specific information. We link to some of our resources, some of our partner organization resources as well. So that will be updated. And then we also have a blog. So some posts on, you know, we have posts for specific practitioners, legislation in general, workforce. So we're really excited. And so that's kind of the really, really great scope of practice website. I don't know, Kelly, do we need to share anything else of our wonderful website again? And I do want to
contact info. Yeah, go ahead. Cindy.
Yeah, there's some contact info at the bottom. And then I do want to thank our wonderful partners at the Health Resources and Services Administration for their continued support of this website. We love working on it. It is a really great resource. So we hope you'll check it out. It's scopeofpracticepolicy.org.
And you all are the first to see the redesigned website.
Yeah.
So great. Thank you, Sydney. That's wonderful.
You're welcome.
We're really excited about that. And I think now we'll transition to a quick run through of the Health Innovations database that we maintain at NCSL. And I think Emily can talk through a little bit of that and what we tag and what we track in this database.
Yeah, thanks, Kelly. We just thought this would be another interesting database to highlight for you all. So NCSL's Health Innovation Database was started in 2015, really to track promising reforms and innovations in the health system. So it covers a variety of topics relating to healthcare coverage and access. So this database has bills related to Medicaid innovations, private marketplaces, price and payment reforms, both in Medicaid and private. Now, I would like to note this database only tracks enacted legislation and it does not track all proposed bills. So, you know, you aren't going to see a lot of bills yet for 2021, but you can certainly look back to see what bills were tagged in preceding years, going back to 2015. So now we'll just go through a really quick search example with you. So you can select the topic from the list here on the page, or there's also an option to type a specific keyword there below. And just want to note there are definitions for each of those topics at the bottom of the page if you're looking for those. But so for this example, we're going to use the Medicaid general topic, which kind of just covers anything Medicaid that didn't necessarily fall into another category. And we're going to put in the year 2021 sorry, 2020, since we don't have a lot of enacted legislation yet this year, and just pull up and hit search and see what happens. And so from here, you can see that there's 38 bills in 23 different states on a variety of topics there. And you can see kind of the general topic of the bill in what state. And at the very top there, there'll be a link that'll take you so you can go see the actual legislation that was enacted if you're interested there. So yeah, again, just kind of wanted to share this resource with you. It's a good spot to go see kind of what unique or interesting ideas states are up to in their Medicaid and other coverage kinds of areas. And with that, I will pass it back to Kelly to close out our session here today.
Yes, thank you so much. So we're running ahead of schedule, and I hope you all don't mind having a couple extra minutes back in your day. I just want to thank you all so much for joining us. Make sure to check out the resources that we shared with you, and also the COVID database. We also the health program also supports the tracking of health-related legislation in a housing database as well, and that was mentioned earlier, so be sure to check that out as well. And I just also want to thank our partners at Health Resources and Services Administration for their support of this session and the Scope of Practice Policy website, and so much of the access to care work that we are able to do at NCSL because of their support. And so thank you all for joining us. Thank you, Emily and Sydney, for sharing your expertise. And we hope that you all enjoy the rest of your State Policy 101 series. Have a great day.